co-host.
Najma, I'm still not the co-host. I'm unable to project. I was requesting the person to make me a co-host so that I project it.
Yeah, okay. I'm sorry about that. Yeah.
Okay, now I mean, thank you. Thank you.
Okay, okay.
Everybody can see my slide.
Yes, it's quite visible. You can continue.
So thank you so much. Assalamu alaikum, each and everyone. I'm called Omar, a level 6 medical student. I'm presenting a case of an acute acute pancreatitis tonight. Sorry. Okay. So I'm presenting a patient by the name JW due to the privacy issues. An age 34-year-old male was admitted at Ward 80, a date of admission 12 days ago, who resides in Bahati, who works as a Matatu conductor. A patient presented with 3 days history of abdominal pain and abdominal distension. Those are the chief complaints. A history of presenting illness. Patient was last well 3 days ago prior to the admission when he presented with abdominal pain, which was gradual in onset and progressive in nature. The pain was more severe in the epigastric region and it was radiating to the back. It was relieved by sitting and leaning forward. It was aggravated by lying supine and walking. He graded the severity of pain as 9/10. The abdominal pain was associated with nausea, vomiting, and anorexia. Patient reports to have 2 episodes of preprandial, non-projectile, and yellow-colored vomiters. He reports to have associated reduced appetite. Patient also reported to have history of heavy alcohol intake, more than his usual, what he usually takes it, on the night before before he lived with the above. He reports to have taken about 800 to 1,000 mils. Sorry, that's about 1,000 mils. That's one liter of a boozer type of a bed he was taking, which is about, in terms of calculation, was about 5.2 units per day of alcohol. A patient denies to have history of smoking, history of NSAID use, history of hematemesis, and history of hematochezia. There was also no history of diarrhea, no history of hematuria, trauma, no history of dysuria, no history of hematuria, and no history of diarrhea. A patient also complained of abdominal swelling, which was global and progressive in nature, with associated bloating, early satiety, and easy fatigue. But there was no associated history of difficulty in breathing, no cough, no history of weight loss, no fever. Patient, he was taken by his relative to a peripheral facility. The symptoms developed at night. He was taken to a peripheral facility in which a blood pressure was taken, which has showed a value of 180/151 millimeter Hg. At that facility, it was a clinic, and he was given sublingual in a Philippine in which for the pressure dropped, but the symptoms still persisted. A patient was referred to KNH, in which the patient was stabilized with IV fluids and analgesics. Blood workups were done and imaging. He was admitted to the wards. While in the wards, the patient was put on NPO to allow the pancreas to recover. IV fluids, normal saline 4 liters, 24 hours alternating with Ringer's lactate. Analgesics, morphine 10 milligrams PD for 3 days. IV ceftriaxone 1 gram BD and IV flagyl 500 mils BD was started. Patient was stable after 4 days and post-admission and was discharged on day 5. Past medical history, he had no previous history of previous admissions, no history of chronic conditions such as hypertension or diabetes, no history of blood transfusion. Family social history, there was no history of chronic conditions in the family, no history of smoking, but he has a positive history of alcohol intake. He reports to have been regularly taking alcohol. He is not under NHIF, active under NHIF cover. Review of system, CNS, there was no headache, no dizziness, no loss of consciousness. Cardiovascular system, there was no dyspnea, no orthopnea, no PND. In respiratory, there was no cough, no difficulty in breathing, there was no chest pain. In genitourinary system, there was no hematuria, no dysuria, no frequency, no urgency. In summary, I am presenting JBW, a 34-year-old male who presented with 3 days history of abdominal pain and abdominal distension. The pain was severe in the epigastric region and it was radiating to the back. Patient reports to have associated nausea and vomiting and anorexia, but he has no history of diarrhea or hematochezia and hematemesis. He also complained of abdominal distension, which was global and progressive in nature, but there's no history of difficulty in breathing, no trauma, no weight loss, no fever. On examination, I found a middle-aged man who is a sick-looking, lying supine in bed with legs flexed, in pain, but he was not in an obvious respiratory distress or nor he was wasted. The vitals on the time of Clarkland examination, BP was 133/87, pulse of 86, temperature of 36.7, and SpO2 of 98. Of note, the patient had only that one episode of high PP at the peripheral facility, but subsequently the patient had never had an elevated blood pressure. A systemic examination per abdomen. On inspection, abdomen was globally distended, but was moved to dispersion, umbilicus was everted. There was hypopigmentation of the skin that was overlying both the chest and the abdomen. The patient reports there was a history of burn, hot water by his wife in 2020. On palpation, superficial palpation, there was tenderness over the epigastric region and the left upper quadrant, and there was guarding of the abdomen. On deep palpation, there was no hepatosplenomegaly. On percussion, it was tympanic. There was no shift in dullness, no fluid trail. On auscultation, there was bowel sounds were present. Respiratory examination, chest is symmetrical with hypopigmentation over the line skin due to the burn. On palpation, there was tactile vocal parameters present. On percussion, resonance sound over the lung field and dullness over the cardiac region. On auscultation, there was bilateral air entry. There was no wheeze, no crackles. Cardiovascular system, the precordium was not hyperactive. Radial pulse was present. It was regular in rhythm and normal volume with no radial delay. Apex peak was 5th intercostal space, mid-clavicular line. S1, S2 had, there was no murmurs. CNS, the GCS was 15/15. He was oriented in time, place, and person. His pupils were bilaterally equal and reflective to light. Cranial functions was intact. My impression based on that was acute gastritis secondary binge alcohol intake, was suspecting of gastritis, intestinal obstruction, acute liver injury, and sepsis based on the full hemogram. So the investigation that has been done while he was in the ward under the casualty includes, so these maybe it's not that much visible. This is the full hemogram of the patient. He had a white cell count of 21.18 with a normal range of 4 to 10. So there is a leukocytosis with a picture of neutrophilia of 18.98 The HP level was 20.3. Hematocrit level was 57.7 high as well. Platelets level was 250 times 10 power L. So, sorry. So this was the full CBC count that was done. Enzyme liver function test UECs were also done. You check a bit, not much clear. For the ALT, the AST level, for the LFT, AST level was 80, which is high, 2 times of the upper limit. Upper limit is supposed to be more than 35, less than 35. ALT 74.5, high as well. Given when the AST and ALT level, you check the ratio that still the AST is higher than ALT, given a more of an alcoholic feature. In terms of synthetic features of the liver, the gamma GT was high to 229.8, the upper limit was 61. Direct bilirubin was 13, high 13.5. Total bilirubin was 31. Albumin level of 42, which is within the normal range. In the UECs, urea was 5.84, upper limit of 8, which is normal. Creatine was 123, in between 70 to 115. Potassium level was low of 3.07. Chloride level was 90. So the patient deranged liver function, LFT, and deranged UECs level. Pancreatic enzymes level were also done, both the salivary amylase and the lipase. And you check, if you check the the salivary amylase, which is the first one, has pancreatic amylase of 523.7, which the upper limit is supposed to be in between 50 to 150. So you have about more than 3 times of the upper limit. The lipase of more than 250, one of the patient was more than 250, and the upper limit is supposed to be 60. So you also have elevated both the lipase and the amylase. This was the referral from the facility he came from. At the ward level, what has been done for the patient was put on nilparol and was started on IV fluids. 4 liters normal saline. It was alternating with ringer's lactate over 24 hours. He was also started, since he was in severe pain, patient was started on morphine 10 milligram BD for 3 days with elevated level of white cell count. He was started on both ceftriaxone and metronidazole. He was started with 1 gram of ceftriaxone BD for 5 days, IV metronidazole 500 mils for 3 days as well. I also forgot to add, he was also added with high dose PPI, omeprazole 40 milligrams, 80 stat, and then 40 OD. After 24 hours post-admission, patient was started on oral intake. IV fluid was stopped. On day 5, post-admission, patient was stable and ambulating. He was advised to stop alcohol intake or reduce it, and he was discharged later on the same day. So that is about the history. Any question before we proceed to the second part of it?
Maybe Dr. Abdiweli has a comment to give.
There are no questions. I think there are not many comments, so we'll proceed to the discussion, then we'll make a consolidated input at the end.
Thank you, Doc. Okay, I think we can start the case discussion. So the case I presented earlier was giving us a picture of pancreatitis. So we wanted to discuss more about the pancreatitis based on the following objective. Definition of pancreatitis, etiology, pathophysiology, clinical features, diagnostics that or the lab investigation that they're going to carry out, the severity, grading and prognostic score, treatment management, and also differential diagnosis and complications of pancreatitis. So definition is an inflammatory condition of the pancreas that arises as a result of an inappropriate activation of the digestive enzymes within the gland. Pancreatitis can be classified either acute pancreatitis or a chronic pancreatitis. Acute pancreatitis has two broad classifications as per Atlanta classification. We have the mild, moderate, and the severe. The mild one is describing more of an interstitial pancreatitis, and severe is when they have necrotizing at a level of necrotizing of the pancreatic gland. Etiology, what causes acute pancreatitis? The most common cause of acute pancreatitis is biliary pancreatitis, which 40% of it is caused by gallstones. The second common cause of which our patient I suspect has it is alcohol-induced pancreatitis, 20% of the cases, and then the rest idiopathic, 25% of the causes of acute pancreatitis. So other causes include one, hypertriglycemia, hypercalcemia, drugs, scorpion poisons, viral infections such as Coxsackie B viruses and mumps, trauma, autoimmune, and pancreas disease. So these are mnemonic they usually develop for the risk factors or what we call the general etiology of pancreatitis. You can just call it I get smashed. The I stands for idiopathic, which about 20% of the causes of pancreatitis was it. Gallstone, which was largest cause of pancreatitis, 40% of it. For the G, E stands for ethanol, or which is alcohol, which our patient had. T for trauma. S in the SMASH first one stands for steroids. M for mumps. A for autoimmune. S for scorpion poison. The H can be either hypercalcemia or hypertriglycemia. ERCP, which is endoscopic retrograde cholangiopancreatography, can also be a risk factor or a cause of pancreatitis. And lastly, D, drugs can cause acute pancreatitis. Let's talk about the pathophysiology of acute pancreatitis, or in general pancreatitis, although the acute pancreatitis can later develop in chronic pancreatitis. So there is a duct obstruction, and this duct obstruction can be caused by, as a result of, for example, a gallstone lying on the pancreatic duct and obstructing the flow of the pancreatic juice into the, so there's a duct obstruction that will lead to a blockage of exocytosis zymogenous granules from the pancreatic acinar cells, which will lead the granules to coalesce with lysosomes and to form autophagic vacuoles. When the lysosomes coalesce, the granules coalesces with the lysosomes and forming autophagic vacuoles, what happens next? The lysosomal enzymes activate the digestive enzyme produced by the pancreatic gland. So when it's been activated, this leads to autodigestion of the gland. So the essence of this one is like the enzymes being produced by the gland is in active form, and they are not supposed to be activated within the gland. If they become activated within the gland, they cause a harm, they cause a destruction to the gland. So whenever they get out of the gland, that's the time they have been activated. So if there's obstruction, they will be get activated within the gland and causing the destruction. This now after that one, it will lead to destruction of the cell injury and death.
Omar, I think we have lost you. Omar. I think his network is unstable.
The responses with the local
Sorry about that. He's having some network issues. He's going to join us in a minute.
Sorry, colleagues. I had a network instability. I'm doing it now. Sorry for that. Najma, I just lost being a co-host. Just please make me again so that I share. Sorry for that.
Ayan, was she? Let me see. Ayan, please make Dubat co-host again.
Thank you. Okay, you can hear me and you can see my screen?
Yes, please go ahead.
Thank you. Sorry for the interruption. So I was trying to talk about the clinical features of acute pancreatitis. So there is a classical features which a patient with acute pancreatitis will present. Number one is a constant severe epigastric pain that classically radiates to the back, that is worse after the meals, and also worse when patient is supine and relieves patient is supine and it relieves on leaning forward. There's also associated nausea and vomiting in which our patient had. There's also fever. If there's a pulmonary complications are present, there may be a chest pain and difficulty in breathing. On physical examination, a patient with acute pancreatitis, what can be the things that you can find it? A patient can be sick looking, dehydrated, with or without pyrexia, also tachycardia, because there's an aspect of shock that may be associated with pancreatitis in case it becomes severe. On abdominal examination, what you may find it tenderness, guarding, distension, and ileus. There may be aspect of skin agents that may be found on also acute pancreatitis. We have a sign that we call the Cullen sign. The Cullen sign is periumbilical ecchymosis, that is redness of around the umbilicus. We also have a sign we call the Gray Turner sign, which is the flank ecchymosis and discoloration along where we have the flank. And then we also have a Fox sign, which is ecchymosis or discoloration along the inguinal ligaments. So those are the physical examinations that we may find on a patient with acute pancreatitis. On diagnosis, so for you to diagnose a patient with acute pancreatitis, you must have two of these three. Number one, the patient must have a typical abdominal pain. The abdominal pain that we are talking about is epigastric pain that is radiating to the back. Those are classical features of it. Number two, we have elevation in the serum levels of both the amylase and the lipase, and they are supposed to be 3 times the upper normal limits. So remember, our patient had severe, extremely elevated, both the amylase and the lipase. Also, the patient can have characteristic features of acute pancreatitis based on contrast enhanced CT scan. Pancreatic enzymes, let's talk about a small, in terms of pancreatic enzymes, we have two being produced. We have serum amylase and lipase. They are both elevated during episodes of acute pancreatitis. The lipase is more specific than the amylase, as the amylase can be elevated in other conditions. You can remember there's also the aspect we call the salivary amylase, so it is non-specific. Amylase can be elevated in conditions such as parotitis and also some malignancies. Lipase, the reason as to why is more specific as lipase persists longer in serum and is more sensitive, therefore is considered as the preferred test compared to the amylase. But note that both the amylase, the levels of how high both the amylase and the lipase has, there is no absolute level that does not correlate with the severity of the pancreatitis. Even if they are extremely high, that does not correlate of how severe the pancreatitis is. Other investigations that can be carried out, that's chest X-ray and abdomen. This one is just to rule out in case of any complications like a pulmonary embolism, pulmonary visions that can be associated with it, to rule out perforated viscus in case for the abdomen. Ultrasound, this is the first line modality for the all patients, for a patient with acute pancreatitis. Before we do even this contrast enhanced, the doc will talk about more about it. So this is the one in which we have done for our patient. We have not done CT enhanced contrast, but we have done ultrasound. MRCP, more sensitive for choledolysis, LFT, elevated AST and LFT, suggestion of biliary causes, the serum calcium level, and also the lipid profile. We will also carry out, you can also do full hemogram, C-reactive protein, procalcitonin, and lactate LDH. In terms of predicting the severity score of pancreatitis, there are several methods that can be used to assess it based on the severity. The number one we can use is the CT severity index. We can also use what we call the Ranson criteria. We can also use the Apache 2 score, which is acute physiology of physiology and the chronic health evaluation 2. We also have the BSAP score, which is the bedside index severity of acute pancreatitis. The Apache 2 is mostly used in ICU setting. The first one, which is the CT severity index, the grade, we usually talk about grade A, B, C, D. For A, in case of a normal pancreas, A has 0 point. B, in case CT scan severity has shown edematous pancreas, have a 1 point. If you have for C, you have B, which is edematous pancreas plus mild extra pancreatic changes, which is 0.2. For D, severe extra pancreatic changes with fluid collection, 1 point fluid collection, that's for 3 points. And E, if you have multiple extensive fluid collections, 4 points. So there is the score of more than 5. They are talking about supposed to be 0 to 3 mild, 4 to 6 moderate, and any value above 7 up to 10. When you sum up these points, it will give you how severe the pancreatitis is. When you come to Ranson's criteria, we usually have these are like more of a risk factors. Age more than 55, a white cell count of more than 16. You can remember our patient had 21, blood glucose of 11.1 millimoles per liter, serum LDH of more than 350, aspartate transaminase of more than 250. And during the initial 48 hours assessment, if you have hematocrit level decreases more than by 10%, blood urea nitrogen increases by more than 1.8 millimoles per liter, serum calcium of less than 2 millimoles per liter, base deficit of more than 4 milliequivalents per liter, and fluid sequestration of more than 600 mils, arterial oxygen of less than 60 millimeter Hg. So the scoring system of all the what we have mentioned above has 1 point each for the criterion, and a score of more than 3 give you a severe disease. So in terms of management, so basically in terms of management of acute pancreatitis, we can classify either both the supportive and the definitive management. So what we usually talk about, you relieve the pain by giving analgesics, and the analgesics of choice usually we use here are NSAIDs in case the patient has, if it's extremely severe, we can use narcotics like morphine that we talk about. You also give fluid therapy, IV fluids, to address the hemodynamic instability and prevent hemoconcentration and optimize hydration. You also need to talk about nutrition for the patient. Early enteral feeding is encouraged, although nasojejunal feeding has been preferred because of reduced pancreatic stimulation. So we are trying to avoid that pancreas, which is under that situation, we don't want to stimulate it and to produce pancreatic enzymes again. So we need to make the pancreas relax. We can give antibiotics, although it's a bit of questionable again. The doc will talk more about it. Antibiotic for those with severe necrotizing pancreatitis. Early interventions for those with ERCP. That's now when you have stabilized the patient based on the cause of what has of the pancreatitis. Now you treat based on that one. For example, in case the patient has a biliary etiology, you will do an ERCP or a sphincterectomy for those with biliary etiology. You give antiemetics and the supportives because the patient has also nausea and vomiting. There's an aspect of hyperglycemia. You also manage that hyperglycemia. The differential diagnosis for a patient with acute pancreatitis may be a perforated viscous, intestinal obstruction, aortic rupture or aortic dissection, a biliary disease, myocardial infarction, diabetic ketoacidosis, because there's an aspect of hyperglycemia. Complications that can be caused by acute pancreatitis include necrotizing pancreatitis, pancreatic pseudocyst, shock, SIRs, sepsis, revision, pneumonia, and pancreatic ascites. So thank you so much. I now open for the doc. I welcome the doc to comment on both the history and the discussion. Thank you so much.
Thank you. Sorry, carry on, Najma.
Thank you so much, Omar, for the wonderful presentation. It was quite extensive, and now we can call upon Dr. Abdiweli to, to comment on the discussion part as well as the history. Doc, you can briefly capture what he has not, what he missed in the history, and then we can, you can tell us 1 or 2, 3 things on the discussion part.
Okay, thank you. And for an elaborate presentation, make it as interactive as possible. Anyone with a question, contribution, kindly don't hesitate to share. And Omar, the history was overall comprehensive, and I think diagnostic. And there are a few things that I think needed to be captured in this case, especially in your history. And on the alcohol use of this patient, I think the focus has been only on his current binge drink the night before his episode of acute pancreatitis. But I think more important in the management of this patient is to manage the cause. And the cause is alcohol. So is the patient, has he had one-off binge drinking? Is this chronic alcoholism? And therefore in your history, it will have been appropriate to capture your cage questions so that we see does this patient have alcoholism or not, okay? And so it's 60 years only or 40 years, everyone? Hello?
We have a mixture. Yeah, we have a mixture.
Okay. So, I hope you understand the cage criteria for alcoholism, and that needs to come in your history in this kind of patients, okay? And again, in your examination, I think it was also comprehensive, but the most important etiology of acute pancreatitis is gallstones, okay? So Omar, in your general examination, we needed to know whether this patient is icterus or not, whether there was jaundice or not, okay? And that will guide your evaluation and also what is the possible etiology, okay? And in terms of your diagnostic formulation, if you can put up your slides of the initial slide, the first presentation. So as he does that, I think in your diagnostic formulation for 60 years, I don't think you need to just list what are the differential diagnoses. So it should be derived from your history, physical examination. And if you're going to do this differential diagnosis before your investigation, then they should largely come from your history and physical examination. But if you're giving us your impression after even reviewing the investigations, then it should reflect from all the three, okay? So, and your acute liver injury, what is missing in your diagnostic formulation is acute kidney injury. This patient had creatinines of 124 or something. So the creatinine, there was azotemia, okay? And the best way to put is acute pancreatitis with organ involvement, okay? Organ failures. And here we have renal involvement, we have liver involvement, okay? And even in your severity assessment, mild, moderate, severe, it's about severe and moderate, it's about the severity of organ involvement. So you have mild is when you have absence of organ failure or systemic complications. So just epigastric pain, risk factor, but no major systemic complications or organ failure. And then moderate is when you have organ failure, transient organ failure. So about 48 hours, it should resolve within 48 hours. If that lasts longer than 48 hours, then that's a severe acute pancreatitis, okay? So this was a patient who has severe, moderate or severe pancreatitis. and the repeat investigations were not given to us, so we don't know whether that resolved within 48 hours or not, but at least we know there was organ involvement. There is the kidney, there is the liver, okay? So in your diagnostic formulations, those will be secondary to severe pancreatitis, okay? Again, and go to your slide on differentials. You mentioned sepsis as part of your impression. I don't think in the history, neither in the examination, that there is anything to support the diagnosis of sepsis in this patient, okay? So by definition, sepsis is when you have two or more, meet two or more of the severe inflammatory response criteria, okay? So either patient has temperatures of more than 38 or has bradycardia, patient has tachycardia of more than 90, patient has tachypnea, patient has leukocytosis or leukopenia of either less than 4 or more than 12, patient has hyperglycemia but is not diabetic, or patient has altered mental status. So I don't think your pressures were okay, your temperature was 36.2, your heart rate was 86 beats per minute, there was no fever in your history, and okay, the only thing I think we picked was leukocytosis, okay? And leukocytosis alone is not diagnostic of sepsis. Sepsis, you have to meet that criteria of 2 of the systemic inflammatory response plus suspected infection. And this suspected infection is where now you have a focus, you have a fever, and you have a potential focus, okay? So I don't think the patient had anything to meet sepsis, okay? And in acute pancreatitis, you get leukocytosis, okay? Not because of an infection, but because of the systemic inflammatory response. You even get leukocytosis with neutrophilia, okay? So that does not necessarily mean that there is an infective process, okay? And that does not warrant initiation of antibiotics, okay?
Okay.
And the other important thing I think you highlighted was in your CBC, important that you pointed out the relative polycythemia in this patient, okay? So HB was 20.3, hematocrit was 57.7, both elevated, and these patients usually have relative polycythemia because of plasma volume depletion, okay? And that's why in the principles of management of acute pancreatitis, fluid resuscitation is the most critical component of the management, okay? So these patients usually have plasma volume reduction for many reasons. Because of the severe inflammation, you get third spacing, you get systemic vasodilation, your patient has nausea and vomiting, patient has inability to ingest, all those contribute to reduction in your plasma volume. And this is obvious from your hemogram. And it's important in terms of your fluid management that you repeat this hemogram and see whether your hematocrit is coming down, and that will be your objective assessment of adequacy of your fluid therapy, okay? And I think in the initial presentation, those were the most important things. It's important to repeat some of these investigations after 48 hours for both assessment of the severity and also clinical response of the patient. In your second presentation, I think the presentation of the acute pancreatitis, overall good presentation, I think captured the most pertinent things. And of importance is in your diagnostic, in diagnosis of acute pancreatitis, you do not need CT scan, okay? So I had Omar mention that we didn't do CT scan, we did an ultrasound. You only need 2 of the 3. And if a patient has typical abdominal pain and has amylase or lipase that's more than 3 times the upper limit, that's diagnostic of acute pancreatitis. No indication for CT scan, okay? So the indications for CT scan is where there is diagnosis is not clear, okay? So patient either has atypical abdominal pain or abdominal pain is typical, but the elevation in the serum amylase or lipase are less than 3 times the upper limit. So you have maybe 2 times upper limit. So does not meet the 2 criteria. Then now you do a CT scan to aid your diagnosis, okay? The other indication is where you are ruling out complications of pancreatitis, okay? And mention ultrasound. Ultrasound, is largely done because the most common cause of acute pancreatitis, we say, is gallstones, okay? So ultrasound is better in picking gallstones or bile duct stones, better than the CT scan. But it's very poor in, it can pick features of pancreatitis, you can pick that on ultrasound, but because these patients usually have ileus because of inflammation, there is poor visibility of both the pancreas and the bile duct. So usually sometimes it's not very good at making a diagnosis. What it helps you is rule out whether this is biliary pancreatitis or not, okay? And I think he went, discussed the principles of management, I think very well. But just to emphasize that principle number one, fluid resuscitation, okay? And that's very effective in the first 24 to 48 hours. And again, the study is showing poor outcomes because we over resuscitate or under resuscitate, okay? So what is advocated for is what's called goal-directed fluid therapy. And this is where you need to have urine output of the patient. You check the heart rate of the patient regularly. So you are targeting for pulse rate less than 120. If you're able to calculate their maps and ensure the map is between 65 and 85, and urine output is more than 0.25 to 1 mils per kg per hour, or you repeat the hematocrit, and hematocrit is within goal, and the goal is 35 to 47. And remember, your hematocrit was 57.7, okay? So once you achieve these goals, then you know that your fluid therapy is working, okay? And there are a few different books you're going to see about the choice of the fluid. There are small studies showing ringas lactate is better than normal saline, but they're very small studies. The theory for advocating for ringas over normal saline is normal saline can lead to hypochloremic metabolic acidosis, to worsen your vasodilatation and attendant complications. And so you might see some literatures prefer ringas lactate as the fluid of choice. Pain management, another second principle of management. Nutrition, important. So the patient is the old teaching of NPO, NPO only until the patient pain has subsided, abdominal pain has subsided, okay? So you don't keep the patient NPO for very long time, okay? And early enteral feeding has been shown to have a better outcome because NPO encourages break. Usually there is break in the the gut integrity, and therefore you get bacterial translocation, and then now you develop complications. Okay. Antibiotics, another important component of the management. Again, there is no indication for prophylactic antibiotics. It's not recommended unless there is an obvious infection in this patient. Okay, patient meets sepsis criteria, and you have investigations to support. You have maybe procalcitonin, and therefore you think there is an infective process going on. But leukocytosis, neutrophilia, those may be just part of the pathophysiology of the acute pancreatitis. So I don't think our patient did not have any systemic inflammatory, no fever. I do not think he required antibiotics. Okay. And then the second last principle is management of the complications. And then the final one is to manage the underlying cause. So if it's what you have is gallstones, manage. If it's alcohol, important that he mentioned he was advised to cut down, but I think that needs to be a bit more elaborate because this patient is bound to come back with recurrent complication. I mean, pancreatitis, and eventually might end up with chronic pancreatitis and more complications. Okay, so important that you address the underlying cause effectively before discharge of the patient. So I think overall those are my comments, but a good presentation.
Thank you so much, Doc.
Are there any comments, any questions?
Guys, if you have any question, you can send to the chat box or you can unmute and say your question. So Doc, I had a clarification. So on one of the complications you guys pointed out was perforated viscous. So can you kindly explain to us how does that come about?
The principle is largely inflammatory, okay? So what even causes the ileus is the systemic inflammatory response as a result of the acute pancreatitis. And sometimes what it leads to as part of the complication is an ischemia of the gut, okay? And that can result in gut perforation. But what more commonly you find is ileus, okay? And other complications are the necrosis. So you can have, depending on whether what you're having is interstitial pancreatitis or necrotic pancreatitis, you can have peripancreatic fluids if it's less than 4 weeks. If it's more than 4 weeks, you get pseudocyst, or you get with the necrotic ones, you get acute necrotic collection if it's less than 4 weeks. If it's more than 4 weeks, you get walled-off necrosis. Okay, and then things like venous splanchnic venous thrombosis. And abdominal compartment syndrome, all as a result of the inflammatory response from the acute pancreatitis.
Thank you. That was elaborate. Thank you. Anybody who has a question for either the doc or Dubat?
It's also important to check the blood sugars of this patient. Small important investigations that you don't. Pancreatitis patients, glucose is both prognostic and also tells you about complications. So you need to have their blood glucose levels. You need to have their serum calcium levels for etiology and prognostication, and then lipid profile. Okay, especially if this patient looks like a patient who could be having dyslipidemia, and therefore that might be a trigger of your acute pancreatitis.
Abdullah is asking a question. So he's asking, Doc, how is the prognosis in the setting acute of pancreatitis if properly managed?
It usually depends on the severity. Severe pancreatitis with multiple organ failure in an ideal setting where there is proper, they are supposed to be managed in ICU. So mortalities of around 3% or something, that's what has been documented. But mild and moderate pancreatitis, the outcome is good as long as appropriate fluid management is done and pain management and early enteral feeding. I don't have the figures in terms of prognosis of the head.
Thank you, Abdullah. I hope that question was answered quite well. I don't see any other question in the chat box. Guys, you can unmute and give us your review, your suggestion, anything.
Hi, guys. Sorry, I raised my hand, but I didn't see. I think Doc didn't pick it up. Thanks, Doc, for the elaborate discussion. That was pretty comprehensive. And thanks to Omar as well for the presentation. So I just add a bit of input, kidogo. I'm not in the undergrad section. I actually finished undergrad, graduated. So I've seen a few of these cases, and like Doc said, proper management, fluid resuscitation, like he's mentioned, is the key to bringing these patients back. And the one thing I wanted to mention is about analgesia, because the patients usually come in severe pain. So Omar mentioned that you could pick NSAIDs and narcotics, and even for that patient specifically, they used morphine, which was pretty right. There's an old adage that you can't pick morphine, because of it would increase sphincter of Oddi spasm and you'd get even more pain. But in the practice, it has pretty been different. I mean, the opposite. You use morphine, they get relief, and early feeding after 24 hours, and you really get good results. So I just wanted to put out that morphine is pretty useful in pain management. Maybe Doc could agree with that, or maybe if he has an input onto that as well. Thanks.
Thank you, Dr. Hamid. I think that's correct position. We don't avoid morphine anymore in all the teaching. And I think one area where we do poorly is the pain management. I asked Omar to add the part of what was done for the patient, and I was a bit impressed that the patient pain was appropriately managed, given that we were given a severity of 9 out of 10.
Okay. Doc, that's okay. We can carry on with the questions.
Okay. If there are any more, if there aren't, then
yeah, I see there are two in the chat box. Ibrahim is asking, what's the timeline to differentiate between acute and chronic pancreatitis if you are in a setting of limited resources, especially when you can't be able to do investigations, including baselines?
So is that one question or?
Yeah, it looks like one question, but basically what it's asking is the difference between acute and chronic pancreatitis.
I can't remember offhand if there is any specific timeline cutoff, but usually it's the complications. You get recurrent acute recurrent pancreatitis, and then you develop now complications. Okay, so when you develop these complications of pseudocyst or walled off necrosis, that now becomes chronic pancreatitis. But I can't remember a specific cutoff between acute and chronic. And then there was something about resource poor setting. Hello?
Doc, we can hear you, yeah?
Hello?
Yes,
sorry, Doc. So I think that's okay. Does anyone want to tell us in terms of the timing, the difference between acute and chronic? Dubat, Omar, you can tell us the timing. When do we say this is acute and when do we say this is chronic?
Najma, let the senior say. I think Dr. Doc is in.
Who is there? Who can tell us more about it?
Largely, it's just a spectrum. So you know that chronic pancreatitis is because of repeated episodes of acute pancreatitis and the antecedent complications that happen. And if a patient presents to you today, the history might be a bit longer, but the presentation of pancreatitis will be similar. But now then, when you evaluate this patient, you find chronic complications of pancreatitis. Okay. And these are the patients that you need imaging as part of the diagnostic evaluation.
Okay, so just to add on what you said, Doc, do we have differences in the pancreatic enzymes when it comes to acute and chronic?
No, so it will still be raised, although there are some literatures you see that pancreatic amylases may not be significantly raised in chronic pancreatitis.
Okay, thank you for that. And do we have a score like for the one for acute pancreatitis?
Score like?
Like, Dubat, tell us a bit of the scores we can use to.
Those are prognostic scores.
Oh, okay. Those are prognostic scores. Okay.
Yeah.
I think there's one more question here that says, please clarify on the calcium. Why is low calcium a predictor for severe pancreatitis?
From your basic chemistry saponification, usually calcium hypercalcemia is the one that is an etiology, is the cause, and that calcium is mopped up. The lower the calcium, the severer the pancreatitis. Okay, so hypercalcemia will point you that this might be the potential etiology, underlying etiology. Hypocalcemia, on the other hand, tells you that this is severe pancreatitis, so has poor prognosis.
Okay, thank you so much. I think those were the questions in the chat box. I believe this marks the end of our discussion. We really appreciate your input, Dr. Abdiweli, and inshallah we look forward to interacting more and learning, more from you, inshallah. Jazakallahu khairan.
Thank you all. All the best.